Hi, my name's Andy Wolff. This is the video to accompany my chapter on arthroscopic management of the labrum, debridement, repair, and stitch configurations. We will begin with labral debridement. This is indicated for minor peripheral tears without instability at the base of the labrum, without significant intrasubstance tearing. I favor this in the very young patients or patients with small labrum. This is a video of the right hip of a female crew athlete with a large cam lesion. She clearly has fraying of her labrum, but no instability at its base. Labral debridement can be performed with an arthroscopic shaver, biter, or cautery device. In this case, I am using an electric cautery device to remove damaged labral tissue, leaving only good, solid, stable labral tissue behind. We'll now move on to labral repair, and I'll go over some things that I do that help me do this in a reproducible way that I feel is safe and effective. Indications for repair of the labrum include tears of the labrum with instability at its base, with limited intrasubstance tearing and no significant signs of arthritis. This is the right hip of a 32-year-old former collegiate and now high-level recreational ice hockey player. He has extensive tearing at the base of his labrum and then paralabral cysts on the extra-articular side of the labrum as a result of a large cam deformity. My initial goal is to expose the acetabular rim behind the labrum, doing that here with an electric cautery device. I then want to remove damaged tissue at the chondrolabral junction so that there is good tissue for repair. Once the debridement is completed from this side, you can make the decision whether to do a formal labral takedown. I make this decision based on whether there is continued damage that I cannot access without a labral takedown, or if the patient needs a pincer resection as well. At this point then I will return my attention back to the acetabular rim and burr down to a bed of bleeding bone. At this point I want to make sure that I have good visualization all the way down to the chondrolabral junction on the extra-articular side so that I can get my anchor placed as close as possible to the acetabular rim. At this point I'll make a percutaneous portal in order to place all of my anchors. I find it helpful in a case where I'm going to use multiple anchors, in this case 5, if I place all of the anchors once at the beginning through a distal anterolateral portal as shown here. Key points about anchor placement through the distal anterolateral portal are that number 1, the portal is made approximately 5 to 6 centimeters distal to the initial anterolateral portal. Number 2 is that you should consider drilling your own holes in order to get tactile feedback. And number 3, it's a good idea to use a nitinol wire to probe the hole that you just drilled to make sure that there is a bottom to it. This is particularly true in the far anterior area of the acetabulum where the bone is very thin, and a protruding anchor could irritate the iliopsoas tendon. Another key point is that you should be looking at the acetabular surface when you drill your holes. The way I accomplish this is I will position the drill guide on the acetabular rim. I will then move the camera intra-articularly and hand the camera to my assistant so that I can drill the hole myself and get the tactile feedback. In this way I can be certain that my anchor placement will not be through the articular surface. You want to avoid this situation, which is a revision case I did recently where there is an anchor placed in the acetabular surface. As I mentioned previously, I like to place all of my anchors prior to passing any of the sutures for efficiency's sake. I have now placed 4 anchors and I'm now looking through the mid-anterior portal back towards the posterior aspect of the hip joint. In this area of the hip, and sometimes in the anterior portion of the hip, this being approximately 9 o'clock posteriorly, sometimes it's easier to drill these anchors from an inside-out position because the bone is very thin and the angle can sometimes be challenging. Now that all the anchors have been placed, I will begin passing the sutures. In this case, I will use a vertical mattress configuration due to the shape and size of the labrum. By that I mean this patient has a fairly large and meniscoid shaped labrum, which will be very amenable to vertical mattress, also known as base refixation, stitch configuration. I feel like in this case that will affect a more anatomic repair. For smaller and or more cylindrical labra, I prefer a simple loop configuration. Once this suture is tied and cut, I can move on to the adjacent suture just anterior to it. For this suture, I will use a grasper through the distal anterolateral portal to stabilize the labrum while I do my vertical mattress suturing. I find this helpful in large unstable tears or in the case of a labral takedown or labral reconstruction. Similarly, a grasping device through an accessory portal can be useful to set the tension and anatomic position of your labrum while you are tying your sutures in order to put the labrum in the most anatomic position possible. Now that I have passed and tied my posterior 2 sutures, I will switch portals and turn my attention to passing the sutures from the 3 anterior anchors. Again, I will pass these sutures in a vertical mattress or base refixation manner, as that is what the anatomy of this particular patient's labrum dictates. When passing the initial suture through the labrum at the base, you want to position the loop so that it is easily grasped when you go through the labrum on your second pass. I therefore will oftentimes move this suture into just the right position so that it will be easily accessible when I go through the labrum to grasp it again. Another important thing to note is that the passage of the suture should occur right at the base of the chondrolabral junction on both the articular and extra-articular sides. On this third anchor from the front, again I will use a grasper to stabilize the labrum so that I can perfectly go through the labrum at just the right level with just the right tension in order to place my vertical mattress portion of the suture. Once all my sutures have been passed and tied, I'll then probe the labrum to ensure good fixation to the acetabular rim and to make sure that there is no further loose chondral damage which I need to clean up. Once the hip is taken out of traction, I can assess the suction seal provided by the repaired labrum on the femoral head by taking the hip through range of motion. This is what it looks like when the hip is relatively extended, and when we get into a higher flex position, this is what it looks like after the cam osteoplasty has been performed. There is good suction seal provided by the labrum, even in high flexion with internal rotation, and no deformation of the labrum throughout this range of motion. I want to briefly revisit the topic of vertical mattress versus simple loop fixation, using a case example to illustrate how the labrum should dictate your stitch configuration. This is the right hip of a 30-year-old marathoner who has a labral tear and a cam lesion. Anteriorly, his labrum is more meniscoid or flattened, whereas when you look more proximally, he has a more cylindrical shape to his labrum. Therefore, on the second, more proximal suture, I'll perform a simple loop suture because of the cylindrical anatomy of the labrum in this area, and also because there is very little tissue through which to put a vertical mattress suture. Many times patients will have a cylindrical labrum throughout the entire extent of the labrum, or a meniscoid labrum throughout the entire labral extent, in which case only vertical mattresses or only loop sutures would be placed. In cases like this, when the anatomy itself changes within the same patient, it's best to vary your stitch configurations to match this anatomy, in my opinion. Here, varying our stitch configurations has restored this patient's anatomy both in traction and out of traction. This is the more superior stitch, which was a loop, and the more anterior stitch, which was the base refixation stitch, both of which have restored suction seal function of the labrum. In closing, I want to review some of the technical pearls we've covered. Number 1, let the shape of the labrum dictate your stitch configuration. Number 2, place the anchors as close to the articular surface as possible for an anatomic repair. Number 3, stay in bone. Watch the acetabular surface during drilling and anchor placement. Drill your own holes so that you can get tactile feedback, and when in doubt, place a nitinol wire down the hole before placing the anchor. Finally, do not struggle with anchor placement. Use an accessory portal if necessary. Thank you very much.